I had a student ping me who just failed her cardiovascular exam. And when I said, I heard it was a farm heavy exam, that must have been tough. And she burst into tears. And what I said to her was, you should be crying. This really hurts. First of all, it's failure, which is always really uncomfortable. It's really embarrassing. And you really tried, so it's really frustrating. So if you don't think I don't understand you, my heart goes out to these students, right? They say, please help me. And I always go, let's talk about how you learned. So when I asked her how she learned, guess what she told me? She didn't have a system. The best I can do that starts to help is to have a plan.
Dr. Tisdall, I understand that you got in trouble with your school this week.
I did, and I had to have a meeting with administration over it, and it really boils around the idea of what is the purpose of testing. And what you've got to understand is schools have meaningful compliance organizations, right? They have to go to national bodies and they have to demonstrate that your testing correlates to learning objective. Now, I personally quite briskly dislike the idea that you have learning objectives because you shouldn't be learning it as though those 10 things are the limit of what you're supposed to know. So my idea of a learning objective is congestive heart failure. You know, that's a good, intact, comprehensive subject that everyone knows you've got to understand from soup to nuts. Not breaking it out into methods of stress, homeostasis to adaptation, remodeling, eccentric to concentric, irreversible progression. You know, you can make 15 learning objectives. But the trouble with that is then you've tied yourself into that rigid structure. So if you want to ask a question, you've got to demonstrate to the compliance people how that matches up. Well, what happens, of course, is the testing tail starts wagging the teaching dog. Because if you say, well, show me your learning objective, and you didn't specifically describe it in your lecture, even though it's an intuitive in between the two, well, it's out. And so what you start to see is you start to see the people that run the exams start to run the exam that you give, because you can't improvise. You can't say, you know, I mentioned this in the lecture, but it isn't in the notes. Oh, no, you haven't written the learning objective and you haven't done it in the notes. It's not fair game anymore. Well, you can just imagine how poorly that works with someone like me, right? In which I believe that the way you learn is for me to do an introduction to the subject. So I'm going to spend 45 minutes, and this is how I want you to teach yourself congestive heart failure. Now, you go away with chapter 16, and you make sure you can draw all the pictures. When you've done that, and you go, you know, I really feel like I've given this a good shot and I know it. Then you come back and we talk about it, because you don't know anything until you've heard it at least 3 times and in 2 different contexts. So you can do congestive heart failure with shortness of breath. You can also do it with a sudden drop in renal function. Boy, that heart-kidney relationship is pretty tight. Well, now you're thinking about congestive heart failure quite differently. Or, for example, you can learn it from congestion, but you know there's forward failure. So if you have an old person and your heart's not pumping out enough, they can have a change in mental status. So all of a sudden you're using all your principles, but lots of different ways so you think about it and embed it differently. So tell me, how do I do a learning objective on that? Because all of a sudden we don't know where the conversation's going because I follow your lead. If you don't seem to know something, I'm going to follow it back till we find out what you have wrong. So it boils down to this other very challenging problem. What is the purpose of testing? And I have a bright line on this. I think there are 3 purposes for testing. The first is the obvious one. Hey, we assigned all this work and we know you lazy dogs haven't done a stroke on it. We're going to give you a test to motivate you. We all need that. I mean, we all understand that perfectly. We all think that's fair. Then there is testing is teaching. I think that the bulk of your exams should be really valuable feedback to you. That if you've learned it right, it says, you got this right, good for you. But if you don't do well, you didn't learn this right. So we should talk. So that becomes one of the most powerful testing tools and learning tools you have. And it's really critical that the student thinks the question is fair and that they went, well, I'm really glad to know now and not when it matters later down the road. So I think maybe a third of learning should be how you respond to your tests. And then the last, which we actually is how most tests are used, is for ranking. Well, I don't think there's any poor idea for medicine, the idea that we rank you, because competence is about knowing your limits. How do you test that? Quality is about consistency. You show up and you always do the rectal exam and the blood pressure. How do you test that? So when we say, let's test knowledge, I would argue you've mastered it or you haven't. So are you allowed to go forward into your next parts of heart disease if you haven't mastered congestive heart failure? I would argue, no, stop, go back and get after it until you've mastered it. So for me, that's the old pass fail, but understand there's a hook on that. Pass is 90%. So you can imagine how philosophically I completely am at odds with the compliance learning objective link people, right? They have an absolutely legitimate administrative obligation. But understand, that's to the institution. I have an absolute fixed obligation to my students. And that is, did you understand what I said? And half of that's on me, right? Whenever I'm teaching, if I ask an idea and the student get it, I don't assume the student is dense. I assume I taught it poorly. So what happened yesterday was the compliance people realized that my predecessor at the position actually hadn't done enough of the questions they wanted to use. And so I get this bomb note that says, hey, we've got this huge slug of questions that would you please get them done in a week? Well, to write a good question isn't trivial. It takes me an hour to write a good question. But because this is learning objective linked, I have to go see what the previous person did, who was a really excellent pathologist. He didn't teach in a clinical pathology way. He just taught Robbins pathology. So it's fine. It's just not what I do. So I have to go watch what he and think about what he said to create the question. So it's not just the hour to think through a thoughtful question that teaches the student. I also have to go and think about what he said. So, you take 19 of those and you add in that length of time, and you can see I have a problem and I resented it. Over the fact that you didn't get that previous person to do that obligation, don't drop it on me because it's better for you. And so I sent a note to the person who sent it, and I said, I resent getting bombed. And the two words I used were, and what you've done is onerous and exigent, which is an excellent word, which means pressing in time.
I just learned that today.
Right? Isn't that great? Whenever I really enjoy that kind of argumentation because it forces everyone to stop and think. Well, you can imagine, these are people that have been running the shop for quite a while, and they resented my resentment. I should just do what I'm told. Well, so the person actually didn't respond to me. Instead, the next thing I know, I've got a department chair and a vice dean appointment. So all you students, if you think this ever ends, you could be a 100-year-old professor and you get called on the mat to say that was inappropriate.
So is that what they did?
Oh yeah, absolutely. Yep.
So what did they say?
Well, they resented my resentment. They have these obligations and they have to get them done. And I should just get on with it. And oh, by the way, it shouldn't take you an hour for the questions we're asking for. They're just quick, snappy questions. And so literally they were told I should be able to do this in an hour and a half.
So you should make worse questions so that they can fulfill their requirements.
Well, I mean, that hurts. But yeah, when I say it's the administration wagging the learning dog, this is what it feels like in life. And so your audience will understand, when you don't get quite what you want out of the system, remember there's a whole back end here you're unaware of. So, the students want me to replace all my predecessors' videos with mine. And what they don't understand is, yeah, of course you're right. You're absolutely right. It's not as simple as that. Because for me to do a thoughtful video, first of all, what are my limits on time? Well, they limit me. It was 8 minutes. Now I'm restricted to 15 minutes after getting, again, another meeting with this is not how we do things here. And me explaining, well, I don't think an idea you can explain in 5 minutes is worth a whole video. So that didn't go well, but they did grudgingly give me 15 minutes. So, but now I've got to say, is it worthwhile for me to do a video on, say, membranous glomerulonephritis when I won't even teach it? You go through all the types of glomerulonephritis. I think you should do one for a kid and one for an adult, and then one if it's a secondary. So I think there should be 3.
Sorry, what are you going to do about those questions then? I mean, first of all, what was your response to them? And second of all, are you going to lower your standard, or are you just going to?
So it's not so much a question of lowering my standard as fitting in. I'm there for the students. It's really not a job for me. As you well know, what we're doing here takes a lot of time and effort. And working full time in an institution is in addition to. And what I've started to doing, and I just got back from being live in person there, and I'm working directly with the students. And it's magic. It's just so much fun. I absolutely love these students. When I say, let's organize this from a patient-centered position, all the same facts, just patient-centered, you can just see that I'm going to learn that because I can see I need to do it this way. So for me, working with these students is absolutely wonderful, but it takes a lot of prep time for me. And every time I do it, I learn something new. So for me, they teach me to teach. So I've got all these live sessions with them coming up. And now all of a sudden I have 19 questions that, irrespective of them being able to do it in an hour and a half, is going to take me many, many hours. And so the resentment doesn't come because they have administration needs. It's because it's giving me the squeeze, in which I'm not putting in where I think the value lies, which is doing this live prep for the students. But my point to all the students who resent their medical school, there are lots of forces above your pay grade. Don't be too quick to judge.
Well, speaking of multiple choice questions, we are going to have a free resource for you guys. It will be linked in the description. 12 multiple choice questions written by Dr. Tisdall. Basically, just throw us your email and we'll start sending them to you. So be sure to check that out.
Yeah, when you get those multiple choice questions, what I want you to think about is how clinical they are, right? So these are all questions that I use to teach this idea of patient-centered learning. And so if you know our images and our way of doing patient-centered progression, they're kind of silly. But if you don't, they're pretty hard. So I hope that the students can see, if they've been using the book and thinking through how we teach pathophys, I get the point you're trying to make, nice question. And if you don't, yikes, remember, step 1 is a clinical exam.
Yes, it is. And in fact, we had a very interesting response to a short that we posted across our channels, where it was a clip from one of your longer form videos, where you basically said medical school is harder for you guys than it was for my generation. And it's not for the reason that you think. And a big part of it is that they think it's harder because they are learning more information. And you said, well, that's not quite true because it's actually a better story. And then what you went on to say is the reason why it's harder is because they are learning from the desk and not in the autopsy rooms and not by the patient's bedside. And I took that clip and I posted it for you as a short, and we had a massive response. So let's go through some of the concerns and comments that students were making. One of the big themes that that came up is that they're all like, well, we all worked with cadavers in anatomy. I don't know what you're talking about, autopsies, how that's any different. Can you explain the difference between cadavers in anatomy and what you're talking about from your experience?
Sure. It's a profound discussion, and it boils down to this really deep philosophical argument. How do you teach a medical student? And I will argue, because we do patient-centered learning, you should know just enough, just in time. So for example, when I come to teach congestive heart failure, why do I have to reteach heart anatomy? And the answer is because if you learn heart anatomy from a cadaver or any other way from someone that isn't clinical, you emphasize things that don't matter. I just really don't care where the coronary sinus is until I'm an interventional cardiologist and I have to figure out where my pacemakers are. But for the medical student, what all they need, they should start with, where is the heart in the chest? So here I've got all these second year, they're halfway through second year, and they can't do a chest x-ray in the sense of they can't do the anatomy of a chest x-ray. Even though they had a cadaver and they dissected the thorax, they didn't learn it in the way that I need them to have it.
Maybe this answers their other comment, which was that, like, I did this. I did what you're talking about. I worked with cadavers and I still learned nothing.
Correct, and they're right. It's not that they learned nothing, is they didn't learn it in a usable way. They learned it in a way that allowed them to answer the questions that were posed based on learning objectives. But the learning objectives weren't written by people that are treating patients. So, for example, this past Monday, I was teaching a review course for the first half of cardiology. And we were doing a dissecting thoracic aortic aneurysm. And I had just a black and white outline of the chest x-ray. And it had a bulge, between the top and the top of the heart. And the students just literally couldn't say, mediastinum thymus, below that's the aortic arch, and there's my heart, so that must be aortic arch. They literally couldn't do that, even though they'd held that aortic arch in their hands when they were doing their cadaver. And that's not a criticism, that's right. I was no different. We did cadavers because they were the only models that we had. Basically, if you were there in 1972, we had a skeleton, a real one, dangling from the hook, and we had a cadaver. And that's how we did our gross anatomy. Now, let's talk about what else we did that was different, because we didn't have the same degree of molecular. So it wasn't that we had less to learn. We just learned different facts. We didn't learn clinically relevant facts. We used to have a 3-hour histology lab and 3 one-hour histology lectures. By the end of that full year course, I was a bad histologist, but I was a histologist. I could think in cells. We could do organelles because we had electron microscopy. What we couldn't then do was follow it into biochem DNA. I mean, it's shocking to realize, but the Nobel Prize for DNA was 1952. That was only 20 years before I started medical school. It was still kind of news. We didn't have CT scans and MRIs. They weren't going to come in till the 80s. We had chest x-rays, which resolved to 2 centimeters. So we didn't have beautiful plastic models that you can break into all the pieces. Oh my gosh, they're so wonderful. We had a skeleton hanging on a hook and our cadaver. And then we did serious histology. So you think how my brain came out of that first year and the second year compared to the students today. No better and without the histology. Well, I would argue, let's just not do the cadavers. They don't smell right. They don't feel right. When you're a pathologist, you deal with every bit of tissue that comes out during surgery. So in that sense, I've probably handled more tissue than almost any other group of people because I did everyone's surgery. And I've sawed bone and decalcified bone, felt 1 million gallbladders, seen 1 million gallstones, everything that comes out. How many appendixes have I seen? So we have this expression in lab, TNTC, too numerous to count. This is what, like when you're looking at red cells in urine and stuff, it's just a sheet of it, go to TNTC. So you can imagine how many colons I've felt, how many colon cancers I felt. And I can tell you with 100% certainty, cadavers don't feel like that. They feel like leather, they're stiff, they're cold, they have this terrible smell. You dissect, they don't have natural planes of parting. Every bit of it's wrong. And there's no reason to ever do that in an age of MRIs and CTs. So I would argue if I was doing an anatomy course, it would be all physical exam, ultrasound, CT, MRI. That's it. And lots of plastic models. So you say, okay, here's your MRI. See it? Do you see it? Good. Now let's do the physical exam. Feel the apical impulse of the heart? Do you feel it? Good. Here's the chest. See where the heart's doing this? You're literally feeling it tap your hand. Because what's going to happen in hypertrophy is it's going to move. So that when I come to teach hypertrophy and the physical exam related to that, and I say lateral movement of the apical impulse, you go, yeah, I've heard that. This is second hit. Good, I'm ready to revisit that. Instead of dissecting this cold, stiff heart, that doesn't move and doesn't feel right, and somehow you're magically supposed to know what the words lateral impulse movement means. Well, you don't. So I have to undo that anatomy and come back to clinical anatomy.
Let's address the comment that students are making about how you had said, you guys are not learning from the patient's bedside. And they go, well, I did patient rounds. I took natural histories. I'm learning from the bedside, and yet I'm still not understanding, not being able to remember this information. What is the difference between an apprenticeship and an observership?
Here's a good example. So if I've stood and watched lots of surgeries, am I entitled to an opinion on surgery? And what I can tell you is absolutely not. If you love the feeling of the needle and the thread, and you can feel it go through the skin, and you pick up your fascia and you tie that beautiful knot, if you love that feeling, that's got to be a third of surgery. The feeling of the mechanical feel of it all, and the movement and the reconnecting. Well, as a student, you don't get to do that. So I would say, do you like to do crochet and knitting is probably a better judge of whether you're going to like surgery than standing at the OR table watching it. The other problem that I have is a universal problem. Your clinicians are fantastic from patient to organ. Your PhDs are totally excellent from the DNA to the proteins and maybe ultrastructure. And then you got this horrible gap, don't you? You've got this horrible gap of cell tissue architecture. And so the reason you're not getting it is you've got two different schools of thought that are absolutely related, except you've got this big hole in the middle. And so that's our idea of completeness. Can you start with the patient symptom and go regional, surface, internal structure, tissue architecture, cell, ultrastructure, protein, DNA, no gaps. So the reason they're having a problem is they've got this whole body of knowledge over here, which is their molecular, and this whole body of knowledge over here, which is their patient, and this gigantic hole in the middle. And make no mistake, I was no different. This isn't a criticism. When I started teaching, I was great from patient to organ, except I'm a histologist, so I could get to cells. Molecular was a complete mystery to me. You can't believe how good it is now, Allie. It's magical. However, I've spent the last 10 years teaching myself. This is how bad it is. If you take a look at deaths in America, I think 22 is the newest data, you're looking at something like 630,000 deaths from heart and 615,000 deaths from cancer. Now, ask how much time the students have spent on heart versus how much they've spent on cancer. I bet it's 4 or 5 to 1. So they're going to walk into these hospitals where they're going to see one of the 160,000 deaths a year from lung cancer, the treatment having been revolutionized with TKIs, tyrosine kinase inhibitors, and they've never heard of them. There's this horrible gap, and that's the gap I really am trying to bridge. And so, when I deal with the MDs, their response is, that looks like a lot to learn. Fine. They get it, right? They get the idea of completeness. When you go to the PhDs, they resent it. Well, that looks like it's really hard to learn. Oh, yes, it's really hard to learn. You have to commit and you have to chip away at it, and you're going to be as ignorant as your students on lots of things. You just have to fess up and say, well, I guess we're all going to learn something here, and they don't like it. And that's how I keep getting voted off islands. You give that group of PhDs a choice between sucking it up and learning to move into the patient, or just keeping the status quo, learning objectives, lots of links, compliance perfect, money coming in, prestige there. They're not going to change.
Talk to me about your comment that students nowadays can learn a better story with medicine, because the feedback we got on the comments section is that it's not better, it's just bulkier. And they actually basically said that you wouldn't be able to learn it if you tried.
Well, I understand their frustration. What they've got to understand is I came out of decades of clinical practice. So I start deeply in the clinical patient side. And that gave me this huge advantage when I came to teach them their basic sciences, because I kept saying, I don't have to learn this because I'm not going to get an exam on it. So that's where we sort of developed this whole idea of #MakeMeCare. So I didn't know any of it. So understand, I'm teaching myself, except I've got this utterly complete understanding of patient care and all the doctors I worked with all my life. So all of a sudden I'm saying, okay, I will learn the tissue, cell, molecular DNA if it helps in patient care. If it doesn't, I got it. It's just another fact, and there's too much to do. So the students have to understand, I've spent the last 13 years saying to myself, how do I take what I already know from tissue through to molecular in a way that you have to know it because it's either explains your test or it's a target for your drugs. Sometimes I do it just because I know it's going to be a target. So what you see then is you can't do the story for yourself. I've been at it for over a decade. It isn't easy. All the time I go to teach and I look at the student's eyes and went, well, that didn't work very well. Then I won't try that again. I'll go and learn something and then I'll try to teach it and I go, well, I can't teach it. So that's not a good way to do it. And so what they don't understand is everything we're going to do is field tested. I've taken this idea and I've taken it to the students and I've watched their faces. And then they go away and learn it and they come back and I say, good, now you explain it to me. So I'll give you an example. I have never successfully taught atherosclerosis. Never. You would think one of the most important diseases we have. I've never done a good job on it. And I'll tell you how I know. Because when I teach across a week, here I am on Monday and I'm teaching circulatory. Okay, well, you're doing blood vessels. You're going to do atherosclerosis. Got it, man. Great explanation. They're all on top of it. Yeah. But on Thursday, I teach diabetes, which causes atherosclerosis. And so I get to test whether they understood it. It's not there. It's not there. And honest to God, I've tried a million different ways. And I realized, you know what I think the problem is? You ready for it? Those stupid cadavers. You thought that's it.
Back to the cadavers.
Because when you do your cadaver, and I did it, everything becomes, how did you learn it? So blood supply of the arm, blood supply of the leg, blood supply of the head. It isn't the circulatory system. So when I say atherosclerosis is a systemic disease, do you think if I have atherosclerosis in my carotid, I probably have it in my renal artery? Yeah, well, you would think, but if you've learned regional blood supplies, you learn renal artery stenosis is unrelated to carotid, is unrelated to coronary. You just see them as separate systems. So when I try to teach atherosclerosis as an arterial systemic disease, they haven't set up their brain in a way that sees a circulation as a system. And so one school actually almost got me to come back to the Caribbean. It said, we'll give you the first 8 weeks when you enter med school. And I got to admit, it still haunts me a little bit because, you know, nothing's smaller than this. Everything has to end in the word system, right? And teaching this idea of completeness. And teaching this idea, it's not your grade, it's mastery. So would you stop being so anxious about everything? And can you just say, if I haven't mastered, I didn't learn right, I'd better learn how to do that so that you come through your first 8 weeks ready for med school, not ready for cram, try to look at the instructor for a little hint, multiple choice question, moving on.
And we do have a whole podcast on anxiety, and you should definitely go check that out. It is the worst. One final question to wrap this up. If there's a student watching this who still feels, dare I say, dismissed by this conversation and thinks, you just don't understand what it's like now for us students, what would you say to them?
I interact with students every day. So if you go back 2 nights ago, I had a student ping me who had just failed her cardiovascular exam. And when I said, I heard it was a farm-heavy exam, that must have been tough. And she burst into tears. And what I said to her was, you should be crying. This really hurts. First of all, it's failure, which is always really uncomfortable. It's really embarrassing. And you really tried, so it's really frustrating. So if you don't think I don't understand you, my heart goes out to these students, right? They say, please help me. And I always go, let's talk about how you learn. So when I asked her how she learned, guess what she told me? She didn't have a system. So what I said was the best way to handle anxiety, which she has, she said she got into the exam, she realized she was missing questions, and that fog descended, and she knew she was cooked. So I said to her, well, anxiety is actually really hard to treat. It really is, especially panic disorder. It's brutal. The best I can do that starts to help, nothing fixes it, but what starts to help is to have a plan. So what I made her do, because it was such a farm-heavy exam, I said, go back to your instructor's notes. And I want you, for every drug you were supposed to learn, I want you to write in a table, indication, mechanism of action, drug interactions, drug complications. And she was supposed to send me 4 of them that night. She only sent me 2, and she said the next day, I fell asleep over my books. Well, that's trying hard. I'm not saying it's trying effectively, but she's really trying. So she finished I pinged her, because sometimes you just need someone to say, hey, get on with it. And so she thanked me for that. And I got the next 2, and in it she said, wow, I hadn't realized how many things I'd left out of my learning. And the other thing that she said was, I guess I have to get over my resentment that they asked me so many tiny facts that clearly aren't very important. I said, yep, get over it. We all have people that have learning objectives, and we all have people that have small details. We all just have to lump that. So what I can't wait to hear now is this Friday, she's rewriting her exam. It's a farm-heavy exam, and she's got a table now so that all of her effort will be so much better directed. And I tell you this story so that when students say, I don't understand, oh, yes, I do.
You really do. I felt that working with you for sure. If you guys found this conversation helpful, be sure to subscribe and let us know if you have any questions or comments. We do read them all. We do answer as many as we can in these podcasts. I am going to link the full playlist in the description, so check that out as well. Other than that, Dr. Tisdall, it's been a pleasure, and we will see you next time.
Bye, Allie. Talk to you soon.